Okay, let's jump straight in. The world is, well, it's getting older, and unfortunately that means more people are facing cancer in their later years. But here's the critical twist. Older adult isn't really a single category, is it?
Not at all.
Someone in their 70s might be running marathons, while, another person in their 60s could be managing multiple serious health issues. How they handle cancer treatment, their symptoms, their whole experience, it's incredibly varied.
Exactly. And this is where traditional ways of thinking in oncology really start to fall short.
How so?
Well, just looking at a patient's chronological age, or using simple scales like ECOG or Karnofsky, which mainly score how well someone moves around, they just don't capture that individual complexity.
That's
In
right.
fact, those simple scores can sometimes penalize older adults, making them seem less capable than they really are in their sort of daily lives.
They miss so much of the real person, right? Like, can they cook for themselves? Do they have family nearby to help? How many medications are they juggling? That's the stuff that truly impacts how someone navigates something as tough as cancer treatment. And that's exactly what we're digging into today. We're doing a deep dive into this important article from CA, a cancer journal for clinicians, which is essentially a guide for clinicians on geriatric assessment in cancer care.
Yeah, and our mission with this deep dive is really to give you a clear, quick understanding of this vital tool. We'll explore why this comprehensive approach is now essential, what exactly goes into it, and maybe most importantly, how it's actually being put into practice to make a real difference.
A difference for older adults with cancer, and also for the people who care for them, which is key.
Absolutely.
For the caregivers, too.
So let's get to the heart of it. What is geriatric assessment, or GA as it's commonly called?
Okay, so think of GA as a 360-degree look at an older person's health status. It goes way beyond just the cancer diagnosis. It's a structured way to evaluate several key dimensions of their life and health. And what are those dimensions? What kind of things are they looking at specifically?
Well, the paper highlights some critical areas. There's physical performance, how they move, functional status, which is often split into activities of daily living, or ADLs.
The basics.
Yeah, the basics like bathing or getting dressed. And then instrumental activities of daily living, IADLs. That's the more complex stuff like managing finances, shopping, using the phone.
Okay.
It also assesses other medical conditions, known as comorbidity. And importantly, how many medications someone is taking. That's polypharmacy.
Which can get complicated really quickly for older adults.
Absolutely. Plus it covers nutrition, how sharp their cognitive function is, their social support system, who's there for them, and their psychological state, like mood and anxiety levels.
Okay, so compared to just saying your ECOG score is 2, which, might mean you're mostly up but can't do strenuous activity, GA tells you if that person can still live independently, manage their bills, and has someone checking in on them. That's a completely different level of detail.
It is. And the article points out that while traditional performance scores like ECOG or Karnofsky, they're pretty good at flagging physical limitations. They don't correlate nearly as well with those other critical domains GA captures, like cognitive function or social support. GA gives you the actual picture of someone's life and, well, their resilience.
This detailed picture sounds incredibly useful, but why does it make such a difference, specifically in cancer treatment? What can GA actually predict about a patient's journey?
This is really where the rubber meets the road. GA information is a much, much stronger predictor than age alone of how well an older person will tolerate cancer treatment, particularly intensive therapies like chemotherapy.
So it can actually predict who might have severe side effects, like really bad ones.
Exactly. Researchers have used GA data to build validated predictive models. These are specifically designed to estimate the risk of serious chemotherapy toxicity. We're talking those clinician-rated grade 3 to 5 adverse events. The paper mentions models like CARG for solid tumors and CRASH, which is used for solid tumors, and also lymphomas and hematologic malignancies.
So these aren't just like educated guesses, they're validated tools based on data.
Right. They take specific variables directly from the GA, things like a history of falls, how active someone is socially, or even their hearing ability for the CARD model.
Interesting.
Or IADLs, cognition and nutrition for the Siderish model. And they use them to stratify a patient's risk level for severe toxicity.
And do certain things pop up again and again?
Well, yeah. While the exact variables might differ a bit between the models, domains like fall history and overall physical function consistently show up as strong predictors across the board.
And is this something that adds hours to a clinic visit? Because, time is always a factor.
That's a great point and a common concern. The article notes that the CARG model can take less than 5 minutes to complete.
5 minutes, that's it.
Yeah, the CIRASH model is a bit more comprehensive, takes about 20 to 30 minutes, so it's designed to be feasible within a busy clinical setting.
You mentioned lymphomas and hematologic malignancies with CRISH. Does GA play a role in predicting outcomes in blood cancer specifically, beyond just chemotoxicity?
Absolutely. GA variables are powerful predictors of crucial outcomes in blood cancers, like acute myeloid leukemia, AML, myelodysplastic syndromes, MDS, multiple myeloma, and lymphoma. Things like overall survival and how long someone can actually stay on their treatment.
Are there specific tools for those blood cancers?
Yes, there are disease-specific risk scores that incorporate GA-like factors. For example, there's the Elderly Prognostic Index for a type of lymphoma called DLBCL. It includes age, comorbidities, and functional status alongside disease features.
Okay.
An MDS-specific frailty index uses things like fatigue and, interestingly, ability to prepare meals. And for multiple myeloma, there's an International Myeloma Working Group frailty score using age, comorbidities, and function.
So the message is?
The key takeaway here is that if you routinely collect ADLs, IADLs, and comorbidity information using GA, you're already getting the data needed to apply these specific, validated risk scores for blood cancers.
Okay, so GA helps predict risks, which is vital for anticipating problems, maybe preventing them. But does it actually change how treatment is given? Does it guide clinical decisions?
It fundamentally does, yes. The paper highlights a systematic review showing that incorporating GA results changed the planned treatment course in a significant number of patients, 31%.
Wow, nearly a third.
Yeah. And often, this led to doctors opting for a less intensive treatment approach.
Less intensive, meaning potentially easier to tolerate but still effective against the cancer. Is that the idea?
Precisely. The goal is to tailor the treatment to the person, not just the disease label or the age.
Makes sense.
The article gives examples from trials. In a lung cancer study, Isoja, using GA to guide treatment decisions, led to fewer toxicities and actually increased treatment. Failure-free survival patients stayed on treatment longer without major issues.
That's a massive benefit, reducing toxicity while maintaining or even improving treatment duration. That's huge.
It is. And in a lymphoma trial, Anzinator 3, using a less intensive chemotherapy regimen guided by a GA-like assessment, was just as effective as the standard regimen in fitter older patients.
Okay.
And even better for very old patients with lower risk disease, mainly because it was better tolerated.
So this isn't just about predicting problems. It's really about making smarter, safer choices for the individual patient based on their overall health.
Exactly. And that brings us neatly to the crucial second step, Geriatric Assessment Management, or GAM.
Okay, so GA is the assessment, getting that detailed picture. GAM is taking that picture and actually doing something about what you see.
That's the perfect way to think about it. GAM takes the specific impairments identified during the GA. Maybe it's poor balance, difficulty managing medications, maybe nutritional issues, and it triggers tailored interventions to address those specific problems. It turns assessment into action.
And this aligns so well with what older adults themselves often prioritize, doesn't it? You hear things like maintaining their independence, staying active, keeping their mind sharp.
Absolutely. GAM directly targets those quality of life outcomes that matter so much. If the GA shows someone is at high risk for falls,
Right.
GM means getting them to physical therapy, maybe doing a home safety check. If they have polypharmacy issues, it triggers a medication review, perhaps by a pharmacist. Nutritional problems mean a referral to a dietitian.
So these interventions aren't necessarily just about fighting the cancer directly. They're about supporting the whole person's health, building them up.
That's key. The paper mentions that recommendations for non-oncologic interventions, things like improving social support, nutrition, managing medications, these come up in over 70% of patients who get a GA. It's about building a foundation of overall health to better withstand the cancer treatment itself.
Okay, so is there concrete evidence that doing GAM, taking these actions, actually improves things for patients? Does it work?
Yes, there's strong evidence now from numerous clinical trials and large analyses, meta-analyses. GAM has been shown to improve really important outcomes.
Like what?
Patients are more likely to complete their planned treatment, they report better quality of life, communication with their care team improves, and important conversations like advanced care planning are more likely to happen.
And what about reducing those negative outcomes we talked about earlier, like toxicity?
Precisely. It lowers the risk of treatment-related toxicity, it reduces falls, and it helps manage polypharmacy. A meta-analysis specifically found a significantly lower risk of treatment toxicity when GAM was implemented compared to usual care.
Reducing severe toxicity, I mean, that's a massive impact on someone's well-being during a tough treatment.
It really is. The article highlights several key trials demonstrating these benefits. The GAIN study, which involved a geriatric multidisciplinary team, saw over a 10% absolute reduction in severe chemotherapy toxicity.
Wow.
And increased completion of advanced directives. The Jericho study focused on frail colorectal cancer patients and found higher rates of completing planned treatment and improvements in quality of life and mobility.
Real, tangible improvements in how people feel and function day to day.
Exactly. Another trial, Integrate, showed patients who received an integrated geriatrician consultation maintained their social function better and had fewer unplanned hospitalizations. And perhaps one of the most compelling,
Go on.
the GAP70+ study. This used an algorithm to provide GA-based recommendations directly to oncology teams in community practices, not just academic centers.
And what did GAP70 Plus show in that community setting?
It showed a marked reduction in clinician-rated toxicities, dropping from 70% in the control group down to 50% in the group receiving the GAM recommendations.
That's huge.
Patients also reported less toxicity themselves. They saw fewer falls, improvements in polypharmacy management, and interestingly, increased initial dose reductions based on the GA results.
Which might make some people nervous.
Right, but crucially, without harming overall survival outcomes. The COACH trial had a similar design and showed improved communication about aging-related issues and higher satisfaction for both patients and their caregivers.
Okay, so the evidence base seems really solid.
Yeah.
Taking action on GA results leads to better outcomes across the board, even if, a few smaller trials maybe haven't shown clear benefits, possibly due to their specific design or maybe outside factors like the pandemic messing things up.
Yeah, the overall utility is well established now, and it's why major cancer organizations like ASCO and SIOG now recommend incorporating GA and GAM into routine care for older adults.
Okay, so with all this compelling evidence, the guidelines now recommending it. You'd think GA and GAM would be standard practice everywhere by now, but the article points out that's just not the case, right? Still lagging.
That's the big challenge, yeah. Despite the known benefits, routine implementation, the actual uptake in everyday oncology practices, is still quite low. A survey cited in the paper found only maybe 22% of oncology providers are regularly using GA.
Only 22%, that's a tiny fraction. Why such a big gap between knowing something works and actually doing it consistently?
Well, the article delves into the barriers providers report. The most common ones are things like lack of dedicated support staff.
Lack of time during busy clinic visits, feeling like they don't have enough knowledge or training on how to perform GA or what to do with the results.
Uncertainty.
Yeah, uncertainty about which tools to use, competing priorities within the clinic or the institution, and just difficulty linking patients to the right supportive care services or specialists after the assessment is done.
So referral pathways.
Exactly. And it seems concerns about resources and time are pretty universal, but providers who are less familiar with the guidelines also feel less confident in their own knowledge about it.
Okay, so if those are the barriers, time, staff, knowledge, pathways, how do we overcome them? How do we make GA practical in the real world, day in, day out?
So the paper discusses strategies framed around this idea of increasing capability, opportunity, and motivation for clinicians. The COMB model. A key development to directly address the time and resource issue is the creation of simpler, more practical GA tools.
Like what? Give me an example. Like the Practical Geriatric Assessment, or PGA. This is developed by ASCO and CureArc. It's designed specifically for routine clinical practice. It's mostly patient-reported, which saves staff time.
Oh.
It takes only about 10 to 25 minutes, covers the core GA domains, gives you clear score cutoffs, and even includes an action chart that quickly translates the results into recommendations. Things like specific referrals or suggesting dose adjustments.
That sounds much more user-friendly for a busy clinic environment, less daunting.
Exactly. But tools aren't enough, right? Engaging the whole oncology team is crucial.
How do you do that?
Well, it means providing education to build knowledge and, importantly, bust some myths about how long GA really takes, and providing training to build comfort and skill in administering and interpreting the assessments. It also often requires rethinking how things actually flow in the clinic day to day.
How can workflow help? Changing the process?
Yeah, you need to integrate GA into the existing process, not make it feel like some extra thing tacked on. The article gives examples. Having patients complete parts of the assessment online before the visit.
Right, using portal technology.
Or having a medical assistant or nurse complete other parts during the rooming process. Using the electronic health record, the EHR, to automatically score it and maybe even pop up suggested recommendations for the doctor or nurse practitioner to review. Embedding GA into the workflow provides the opportunity and makes it less of a separate burden.
And who drives that kind of change? Who makes it happen?
It really requires clinical champions within the practice. You need people who are enthusiastic and can lead the implementation effort.
So doctors and nurses?
Yeah, often physicians, nurses, or PAs. They can form teams to manage the whole process, from exploring options, preparing the staff, implementing the changes, and crucially, sustaining it long term. That includes checking if it's actually working, providing feedback. And there are resources out there from organizations like CARG, CO, ACCC to help practices do this.
You mentioned using electronic health records. How else can technology help with getting GA and JAM implemented more widely?
Technology is becoming a huge enabler here. Collecting GA data digitally, whether it's through patient portals or web-based tools, is increasingly feasible.
Even for older adults, there's that talk of the digital divide.
Well, the paper notes that while that's been a concern, the gap is closing rapidly. We've seen significantly increased smartphone and internet use among older adults in recent years. So tech adoption is rising. And EHR integration is key for making the assessment and the resulting recommendations just part of the routine clinical flow, not a separate spreadsheet somewhere.
And telemedicine, that exploded recently. Does that fit in?
Oh, absolutely. Telemedicine is a natural fit for delivering GA and JAM, especially the consultative parts. It allows for virtual assessments, remote communication of action plans to patients and their caregivers,
Right.
and easier access to those supportive care specialists like physical therapists or social workers. This is particularly valuable for patients in rural areas, or maybe those with mobility issues who find travel difficult. Hybrid models using both virtual and in-person elements are also being explored.
What about things like, smartwatches or fitness trackers? Wearables?
Yeah, mobile health technology like wearables can provide real-time data on things like activity levels, gait patterns, maybe even vital signs or sleep. This data could potentially alert the care team to changes in a patient's status between visits, or help tailor recommendations like exercise plans more dynamically.
Okay, so now we're talking about generating a huge amount of data from lots of different places. The GA, the EHR, wearables. What about advanced analytics, AI?
Yeah, that's definitely the frontier.
Yep.
Machine learning and AI have the potential to combine all this diverse data, the GA results, the EHR data, claims data, maybe wearable sensor data, to create even more powerful predictive models than we have now.
Like what?
Well, imagine as a sort of digital twin for a patient, using all this information to simulate how they might respond to different treatment options before you even start.
Wow, that sounds really exciting, almost science fiction. What are the hurdles to getting there? It can't be simple.
No, there are significant challenges. Lack of infrastructure to actually combine these massive data sets from different sources is a major one. Data sharing is complex, technically and legally.
And ethically.
Absolutely. There are important ethical concerns. Ensuring patient privacy and data security is paramount. Addressing potential bias in algorithms. We don't want them disadvantaging certain groups. Ensuring equitable access to these advanced technologies. And making sure the AI's recommendations are transparent and understandable, not just a black box.
Okay, so while the promise is huge, implementing advanced tech for GA needs really careful consideration of the practical and the ethical implications. That makes sense. Now, as the older population itself diversifies, how does GA fit into ensuring equitable care for everyone, not just the majority population?
This is a critical area the article really highlights. The older adult population is becoming increasingly diverse racially and ethnically. And we know that structural inequities, things like systemic racism, contribute significantly to health disparities.
So how can GA help?
Well, GA has the potential to reveal important social determinants of health that impact care, especially if you use tools that maybe assess community-level needs or social vulnerability alongside the individual assessment.
So it can help us see that bigger picture beyond just the medical conditions, the social context.
Yes, exactly.
Yeah.
But a challenge is that most of the research on GA and JAM so far has involved patient populations that aren't very diverse, often majority white participants. There's a real need to figure out how to effectively implement practical GA approaches in underserved communities and rural areas where diversity is often greatest.
And language barriers must complicate things even further, right?
They absolutely do. A significant portion of the population speaks English less than fluently, and a large percentage of those are older adults. Language barriers severely impact communication, the quality of care people receive, their adherence to treatment, safety. It contributes to mistrust and potential discrimination.
Yeah.
We saw this amplified during the pandemic, actually, with lower telemedicine use among some non-English speaking patient groups.
So how can GA help bridge that specific gap?
Well, GA interventions that focus on improving communication, like those tested in the COSIH trial, could certainly help. But fundamentally, delivering truly patient-centered care for people with limited English proficiency means really understanding their preferences within their specific social and cultural context.
It's not just about translation.
No. The article emphasizes the need for research to actively include diverse populations and focus on solutions to these complex issues. Ensuring equitable JAM requires health systems to actively address these social factors through awareness, adjusting care plans accordingly, providing assistance like interpretation or referrals to community resources, and even advocating for broader system changes.
It's clear that reaching diverse populations equitably is a major focus for the future of GA. The article also shines light on another group who are absolutely essential, but let's be honest, often overlooked: caregivers. How does GA relate to their needs?
Right, caregivers. They're often older female family members, maybe a spouse or daughter, and they play a vital role, but frequently experience significant burden.
Burden meaning?
Meaning negative impacts on their own emotional, social, financial, and physical well-being. And this burden is often directly linked to the patient's level of impairment, particularly in those activities of daily living and instrumental activities of daily living that GA measures so well.
So the patient's functional limitations directly create challenges and stress for the person caring for them. It's interconnected.
Precisely. And these caregivers often have their own health issues to deal with. They tend to be in their 60s on average, with their own medical conditions. Studies consistently show caregivers of older adults with cancer report higher rates of emotional distress, physical health problems, and they're less likely to get preventive care for themselves because they're so focused on the patient.
And that burden isn't just hard on the caregiver personally, it can affect the patient's care too.
Yeah, it can actually impact their ability to provide that care effectively. High caregiver burden has been linked to things like more hospitalizations for the patient, or maybe less appropriate end-of-life care because the caregiver is just overwhelmed.
Are we getting any better at assessing caregiver needs, just like we're trying to do systematically for patients with GA?
Well, validated tools exist to screen for caregiver distress, things like the Cancer Support Source Caregiver Tool. And studies have shown it's feasible to use GA-like approaches to assess caregivers' own health and their supportive care needs. However, implementing these tools in routine oncology practice is still very limited. It's not standard yet.
It sounds like, similar to the patient side with GA moving to GAM, we need to move from just knowing about caregiver burden to actually doing something systematic about it.
Exactly. While there's been research on supportive interventions for caregivers, things like problem-solving support or psychoeducation, these studies have often been small, lack diversity in their participants, and the findings can be hard to translate into everyday clinical practice.
So what do caregivers themselves say they need?
Caregivers themselves have identified what they need most. A workshop highlighted 5 key areas: better information and training on how to provide care, being more integrated into the patient's care team, getting help navigating the complex healthcare system, more focus and support for their own health, and broader policy changes to support caregiving.
So the future really needs to integrate caregiver assessment and support directly into the patient's geriatric assessment management plan, recognizing they function as a unit, a dyad, and you can't effectively care for the patient without considering and supporting the caregiver too.
That's absolutely the clear direction the field is and needs to be moving, treating the patient-caregiver dyad.
Okay, let's try and bring this deep dive together then. We've explored how geriatric assessment is really transforming cancer care for older adults. It provides this rich, comprehensive picture that goes way beyond simple age or those basic physical scores.
Right. It's a powerful tool for predicting how patients will tolerate treatment much better than age alone, and for guiding smarter, more personalized therapy decisions.
And then Geriatric Assessment Management, GAM, takes those insights and turns them into concrete action, implementing tailored interventions that we've seen significantly improve key outcomes for patients, reducing toxicity, improving quality of life, enhancing communication, big impacts.
Yeah, and while those practical implementation challenges definitely exist, time, resources, training the field is actively addressing these. Through simplified tools like the PGA, rethinking clinic workflows, training teams, and importantly, leveraging technology like telemedicine and mobile health.
And critically, the focus is expanding, needing to expand more to ensure this comprehensive approach is available equitably to the increasingly diverse older adult populations we see, and also to finally recognize and support the vital needs of the caregivers who are truly partners in this journey.
Yeah, this article makes it really clear that the future of cancer care for older adults has to be holistic, it has to be personalized, and it has to recognize the unique strengths and challenges of each individual and their support system.
So, as you, our listener, reflect on all of this, maybe consider this. Given the really clear evidence that geriatric assessment and management significantly improves outcomes for older adults with cancer, and the fact that implementation is still challenging, what do you think is the single most important step needed right now to ensure this comprehensive care reaches everyone who could benefit, regardless of who they are or where they live? Something to think about.